Full screen అయిందా? Full screen అయిందా వీడియో? అయిందా? అందులో అయిందా?
5 seconds.
అవ్వలేదు అనుకుంటున్నా.
ఇప్పుడు అయింది.
ఓకే ఓకే ఓకే, you can go live. Live start అయిందా? Very good afternoon. I do hope that the slides are visible and the audio and video is also clear. We welcome you to this session of Cuddles online neonatology lectures. Today's session, we are going to discuss about therapeutic hypothermia in hypoxic ischemic encephalopathy, which is now the standard of care. We can say standard of care across the world for the management of hypoxic ischemic encephalopathy and for prevention of mortality, acute onset encephalopathy, as well as long-term disability. So in this presentation, we shall be discussing the introduction to therapeutic hypothermia and how it evolved, different devices used for therapeutic hypothermia. We shall be discussing about both low-tech and high-technology devices. We will be discussing about therapeutic hypothermia trials of HIE in India, as well as review of trials in the low and middle income countries, systematic review of trials. We shall also be discussing about the problems of instituting hypothermia in low and middle income countries like India, and why it has been in the midst of a lot of debate and controversy of late. We shall be also discussing the cost of therapeutic hypothermia devices, as well as the cost-benefit ratio, as well as ethical challenges in this particular intervention, and possible newer avenues of neuroprotection to conclude the session. This talk will be followed by a video of demonstration of two types of therapeutic hypothermia device from our unit, one high-tech device, a servo-controlled device, as well as one low-technology phase-changing mattress device. Right. So therapeutic hypothermia, we all know, has become the standard of care for term newborns with perinatal hypoxia. In India and other low and middle income countries, it is yet to gain complete momentum, although a lot of centers are able to do kind of therapeutic hypothermia to perfection. They have robust protocols, as well as state-of-art infrastructure and accurate monitoring to be able to deliver therapeutic hypothermia well. Now, why has there been a resurgence in interest in therapeutic hypothermia? For a long time, we have known that cooling of the brain has produced powerful intra-ischemic neuroprotection during cardiac surgery. It has also been extensively used in adult post-traumatic brain injury. And new concept of hypothermic post-insult neural rescue also has developed. The shift in thinking or shift in interest towards therapeutic hypothermia was possible because of three new ideas that evolved around the same time. The concept of delayed post-ischemic cell death, secondary energy failure, and excitotoxicity. So all these concepts gave the energy and enthusiasm that there is scope or there is opportunity for an intervention which when kind of introduced between the timing of primary energy failure and secondary energy failure, that is before secondary energy failure starts. This intervention is possibly capable of significantly reducing the neurological sequelae, both acute and long term. This hope gave rise to the concept of the advent of therapeutic hypothermia in neonatal hypoxic ischemic encephalopathy. So in order to understand the timing of the intervention, it is important that we understand that when we are talking about hypoxic injury, there is a phase of primary cell death, as we can see on the left extreme here, immediately after the hypoxic insult occurs. And this is predominantly characterized at the molecular level by the failure of the sodium potassium ATPase pump or high energy phosphate pump. This leads to the accumulation of hydrogen ions and acidosis. It also leads to the ongoing depolarization and entry of calcium. And this can lead to energy failure. This can lead to the release of the downstream cascade of neurotransmitters, which can lead to cell lysis. Following this, there is a latent phase. This is followed by the activation of neurotoxic cascades during the latent phase, which can last for a few minutes. This can last anything between 6 hours to as long as 72 hours. And this is followed by the secondary energy failure phase. During secondary energy failure, there is not only delayed neuronal cell death and apoptosis, but also excitotoxicity because of glutamate and other high energy excitatory neurotransmitters. So this concept of the latent phase gave rise to the thinking that when therapeutic hypothermia and neuroprotective modalities are introduced at this stage, we could potentially prevent a significant damage. Mechanisms of action of neuroprotection due to therapeutic hypothermia include reduction in brain metabolism by 5 to 7% for every degree centigrade drop in the core body temperature. So when we say that while doing therapeutic hypothermia, the core body temperature is decreased to 33.5 degrees Celsius, which is a 3 degrees centigrade drop from the normal core body temperature. This reduces brain metabolism by around 15 to 20%. Automatically, this also reduces the demand for high energy phosphates, glucose, etc. Therapeutic hypothermia also reduces glutamate release, and glutamate is an important neurotransmitter for mediating excitotoxicity. It also reduces the generation of reactive oxygen species and upregulates the anti-apoptotic or cell survival pathways. It has anti-inflammatory effects by reducing both production of pro-inflammatory cytokines and by increasing the production of anti-inflammatory cytokines. TH reduces cerebral blood flow linearly. This is accompanied by reduction of reperfusion-mediated injury. So for every degree drop in temperature, the cerebral blood flow also decreases linearly. So we all understand that there is a significant component of reperfusion-mediated injury in hypoxic ischemic encephalopathy, which is also effectively reduced by therapeutic hypothermia. Now, evidence from the randomized controlled trials performed in high-income nations has been consistently shown to favor the intervention. As you can see here, this is the forest plot of the landmark randomized controlled trials, all of which are from high-income nations, performed from 1998 to 2010, over around a decade. All these studies almost consistently showed that the use of therapeutic hypothermia resulted in a significant reduction in the combined outcome of death and neurological disability. So you can see the names of some of the landmark trials. The Azopardi et al. Trial quoted topmost is the Toby trial, which was a UK-based trial. It showed a trend towards reduction of the outcome of mortality and neurological disability, which was one of their main outcomes. The later trials which have been listed here, most of them you can show that the relative risk is less than 1, indicating a reduction in the outcome. And the 95% confidence intervals for the last 4 trials suggest that they do not cross the line of null effect, indicating statistical significance favoring the intervention, which is therapeutic hypothermia. So the pooled relative risk is 0.76, which shows that there is a 24% reduction in the combined outcome of death and neurological disability, and this is statistically significant. So this is what studies from high-income countries have been consistently suggesting. So in view of consistent benefit, the trials that were performed a little later, some trials like the ICE trial from Australia, they had to be stopped interim because the ethical committee, the ethics, the principles of ethics showed that continuing the trials would result in depriving the intervention and useful intervention for those infants randomized to the control group. So in view of these concerns, these studies had to be even halted midway. So there is no doubt that evidence from the high-income countries has been consistently favoring the intervention therapeutic hypothermia in the form of reduction in the combined outcome of mortality and neurological disability. Now let us understand different devices that are available for performing therapeutic hypothermia. These include some high technology and some low technology devices. The high technology devices usually have continuous core temperature monitoring, which can be either performed with a rectal thermometer probe or an esophageal thermometer probe. And the low technology devices do not really have continuous core temperature monitoring. And both induction, maintenance of cooling, as well as rewarming may have to be done manually. So some of the high-tech devices that we have include Blanketrol, Ticotherm, Criticool, and CoolCap. CoolCap is one device that was used for selective head cooling in one of the earlier trials. We have both Ticotherm, completely servo-controlled device, and we have another form of Ticotherm that was used in the Helix trial, wherein rewarming phase alone was done manually. The low technology cooling devices included natural cooling or passive cooling by using fans or switching off the radiant warmer, which are not generally recommended. Use of water bottles filled with cold water, fans, gel packs, refrigerant gel packs, which were used in earlier trials from JIPMER in India, and phase changing mattress, the Mira cradle mattress, which we shall be seeing in the demonstration now. So this is a slide showing comparison of different devices. Some of them use mattresses which have the circulating coolant liquid, and some devices may rely on the use of a wrap like Criticool, whereas in CoolCap, the baby is provided selective head cooling using a cap which has circulating coolant gel. The coolant can be based out of either plain water or it may be an alcohol-based coolant liquid. Type of cooling can range from whole body cooling to selective head cooling. Selective head cooling was possible using the CoolCap in the CoolCap study. Some devices may also have pre-cooling phase. With the manual rewarming device like Ticotherm TS, there can be significant nursing input that may be required. But if it is a completely servo-controlled device, wherein both cooling and rewarming is servo-controlled, it does not require significant nursing inputs. The recurring expenses may be only in the form of the cooling wrap, which has to be changed periodically or whenever there is physical damage. And some of these devices, particularly Criticool, can also be used for initiating therapeutic hypothermia during transport. Each of the devices comes with its portability advantage versus nil. But most of the newer devices, there are a couple of newer cooling machines that are low cost, that are made in, that are coming from Indian companies, which are also now being portable. Now, some of these devices in detail. This is the Ticotherm device. Ticotherm was used in the TOBI trial earlier, and it is now available in India. It uses an alcohol-based coolant liquid, and it is used for providing whole body cooling. So this is also a portable device, can be used during transport. Even TOBI trial used Ticotherm for initiating therapeutic hypothermia during transport because they included a lot of outborn babies. So rewarming phase, as we discussed earlier, is available either completely servo-controlled in one version, whereas in the version that was used in the Helix trial, manual rewarming was done. This is the completely servo-controlled Ticotherm device. This was the selective head cooling device, which was used in the CoolCap in the earlier trial by Gluckman et al., where it's a water-based coolant that is circulated in the form of a cap that is placed over the baby's head, and this is used for providing selective head cooling. Again, here rewarming might be manual. Now, how do we generally control or monitor the core temperature. Usually a nasopharyngeal temperature probe is used with this particular device. And now we can discuss which is better, whether it is the selective head cooling versus whole body cooling. Usually, whole body cooling is preferred because it results in significant cooling of the circulating blood, and hence there is more effective cooling of the deeper brain structures, deep brain matter, etc., when compared to selective head cooling. On the other hand, we have a lot of low-tech devices which are available, particularly in our country, starting from the gel packs, just using fans, air conditioners, which may result in passive cooling or switching off the warmer, use of water bottles filled with cold water, which are not recommended because they are associated with high failure rates, and there is inconsistent maintenance of core body temperature. There can be accidental severe hypothermia, which can result in significant morbidity as well as mortality. Now, as a via media, the phase changing mattress was quite popular, and many units have been using it. They are continuing to use it even today. So this relies on the principle of using a phase changing mattress. So at room temperature, this is generally solid and it absorbs heat from the newborn. And the mattress may change state from the solid state to the liquid state. It is essential to maintain these mattresses at a certain at a steady temperature, but they may need to be frequently reused or replaced. So usually the manufacturers give us 2 or 3 mattresses for being replaced during one phase of hypothermia itself. For 72 hours, we may have to change the mattress 2 to 3 times. Then we may have to recharge them by keeping it back in the refrigerator. The cost of these mattresses range around rupees 7,000, and the whole device comes for roughly around 2.5 to 3 lakhs. This is much more inexpensive when compared to the servo control devices. However, these also use a lot of nursing inputs, and the nurses have to be manually monitoring the temperature of the infant, and if the temperature rises above the target range, they may have to introduce the induction mattress. Whereas if the temperature goes too low, they may have to switch on the radiant warmer. So this includes continuous nursing monitoring. Now let us discuss the various indications of cooling. Now, do we cool all infants born with asphyxia? The answer is no. So there are some strict selection criteria. These criteria include choice of appropriate gestational age and birth weight to begin with, as well as postnatal age within which cooling has to be initiated, and conclusive evidence for birth asphyxia as well as clinical staging of hypoxic encephalopathy. So starting with the first criteria, the generally accepted gestational age range for starting therapeutic hypothermia is gestational age more than or equal to 36 weeks with a birth weight more than equal to 2,000 grams. Using therapeutic hypothermia at lower gestational ages and lower birth weights has generally been discouraged or deferred for fear of the high risk of morbidity with hypothermia in preterm and low birth weight infants. Generally, cooling needs to be initiated within 6 hours of birth. This is because of the fact that the latent phase prior to the onset of secondary energy failure may range anything between 6 hours to 72 hours. These are the 95% confidence intervals of the latent phase, which precedes the secondary energy failure. So if for a particular baby, newborn, the latent phase is just 6 hours and therapeutic hypothermia is initiated later, it is possible that secondary energy failure had already started before our initiation of therapeutic hypothermia. Hence, it is recommended that ideally the postnatal age at initiation of cooling should be below or equal to 6 hours. This is assuming that the hypoxic insult exactly coincided with the time of birth of the baby. However, a study has shown that initiating cooling between 6 to 24 hours from postnatal from birth did not result in any significant harm. However, this has still not translated into standard practice. So for all practical purposes, we are kind of legitimate in starting hypothermia for neonatal hypoxic ischemic encephalopathy only below 6 hours of postnatal age. Next, there must be evidence of birth asphyxia, which in inborn infants is relatively easy to define by either the presence of an Apgar score, 10-minute Apgar score of below 5, or need for positive pressure ventilation beyond 10 minutes, or presence of significant acidosis as evidenced by a cord arterial or capillary postnatal capillary pH below 7 and base deficit more than 16. In outborn newborns, the criteria for defining birth asphyxia has been debated widely, and it may include one of the following, which includes clear-cut absence of cry or first breath at 5 minutes of age, and the need for positive pressure ventilation provided from the history required until 10 minutes of birth. Other criteria like the presence of cord, blood gas, metabolic acidosis may be more difficult to obtain in an outborn baby. The last and possibly very, very important criteria is the clinical staging of encephalopathy, which can be performed either by using Sarnath staging or Thompson staging. There must be the presence of at least moderate to severe encephalopathy or stage 2 to stage 3 HIE based on either of these staging systems. This includes the presence of clinical seizures, altered state of consciousness or encephalopathy, defined as excessive lethargy, stupor, or coma. So the presence of arousability with deeply painful stimuli may qualify for stupor, whereas a baby who is not arousable by both painful stimuli and by the regular stimuli is supposed to be comatose. As well as the presence of any one of the following, including hypotonia, abnormal neonatal reflexes, including oculomotor and pupillary reflexes, and the presence and the absence of suck reflex. These criteria may be the same for both outborn and inborn infants. So one must note that the presence of other advanced criteria like amplitude integrated EEG, evidence of abnormal electrical activity, either in the form of burst suppression, isoelectric pattern, or low voltage discontinuous pattern. These are not mandatory for the initiation of therapeutic hypothermia. Wherever possible, wherever it is feasible, this may add additional value. But what we really need is a baby who is more than 36 weeks and more than 2,000 grams, who has presented to us within 6 hours of birth and who is satisfying the criteria for evidence for birth asphyxia as well as evidence of moderate to severe encephalopathy on clinical examination. Once we have started therapeutic hypothermia, then one also needs to monitor the infant very closely. Monitoring includes some clinical parameters, vital signs, some EEG parameters, lab parameters such as coagulation studies, blood glucose, and complete blood counts, as well as some neuroimaging parameters. So in terms of clinical staging of encephalopathy, the newborn needs to be monitored for HIE every day, preferably once in 12 hours, but at least once in 24 hours. And encephalopathy can be performed by any of the standard staging tools, such as Thompson staging, modified Sarnath and Sarnath staging. And there are some other newer tools like the NACHT staging system. In addition, the baby needs to be on continuous cardiopulmonary monitoring, which would include heart rate, respiratory rate, saturations, ECG, wherever possible, ECG should be added. And all these parameters obviously will require a multi-para monitor and not merely a pulse oximeter. ECG is recommended because of the likelihood of STT segment changes in the ECG in newborns who receive therapeutic hypothermia. These parameters need to be monitored continuously. The presence of the monitoring of pain using a neonatal pain score like Neonatal Infant Pain Scale or NIPS can also be added to the monitoring tools, and this is preferably to be done once in a day for the first 3 days. In addition, the baby needs to be monitored continuously for urine output. Diaper weighing can suffice if the newborn is reasonably hemodynamically stable. Core temperature monitoring forms a vital part of the therapeutic hypothermia intervention per se. This can be either done using a rectal probe, which is a common way of monitoring core temperature, or nasopharyngeal probe or esophageal probe. This is generally displayed continuously in most of our devices, and it is to be monitored every 15 minutes for 4 hours. Wherever we are monitoring it intermittently, this is the frequency at which it must be done. Wherever available, cerebral function monitoring, CFM or EEG, must be used for monitoring the neurological status of the infant. And if available, it must be used continuously during the cooling phase. Now, in terms of coagulation studies, one must try to use coagulation studies judiciously. If possible, it must be done at admission and one more time, maybe at around 48 hours of therapeutic hypothermia because of the high incidence of DIC or coagulopathy during cooling. Blood glucose levels must be monitored 6-hourly during the entire phase of therapeutic hypothermia and complete blood counts, preferably at admission, and once again, if there is any clinical deterioration. Other lab parameters like serum electrolytes, calcium, urea, creatinine, and magnesium may be monitored once at admission and again based on the clinical requirement. A lot of units, including ours, may perform electrolytes and urea creatinine only after the completion of 48 hours. At 48 hours, one may also want to add liver function test in addition to the other parameters that we just discussed. A blood gas would be usually performed at the time of birth for verification or confirmation of the evidence of birth asphyxia itself. So as we already discussed, pH less than 7 and base deficit more than 16 becomes one of the important variables for defining the presence of intrapartum hypoxia. So this is to be done at admission and can be repeated based on the clinical requirement. So if we have a severely acidotic blood gas at admission, one may generally correct it using fluid and preferably with inotropes if the baby has hemodynamic instability, and then less often with bicarbonate infusion if all other correctable causes have been addressed, and then we may need to repeat the blood gas to ensure that there is improvement in the pH based on the clinical status of the child. Neurosonogram, especially with measurement of some special markers like the resistive index measured from the anterior cerebral artery or ACA, is also recommended at initiation of cooling and may be repeated if the first neurosonogram was abnormal. The role of MRI, particularly with diffusion-weighted imaging and magnetic resonance spectroscopy, has evolved a lot in the last few years. So now it has been recognized that most of the newborns who satisfy the criteria for therapeutic hypothermia should ideally get magnetic resonance imaging of the brain along with TWI and MRS, preferably at around the end of the first week, around day 7. So this timing ensures maximum sensitivity as well as specificity for MRA. Now, having discussed everything about why cooling, what is the right phase to initiate cooling, and evidence from high-income countries as well as various available devices, as well as a clinical protocol for the indications for initiation as well as monitoring, let us discuss some unique aspects from the Indian perspectives that could change the way therapeutic hypothermia is being perceived. Although neonatal encephalopathy continues to be a major cause of mortality and morbidity in all countries, including the lower income countries, low middle income countries, therapeutic hypothermia is still being debated for various reasons in countries such as ours. This is because of the following factors. The most important is likely the lack of continuous antepartum monitoring or intrapartum monitoring in a lot of deliveries, making it difficult to know the exact time of hypoxic insult. So it may be difficult to kind of exactly ascertain the timing of onset of hypoxic insult, and hence the efficacy of therapeutic hypothermia as an intervention. Also, the right time for initiation of therapeutic hypothermia may become more difficult to decide in our country. So, for example, if one doesn't know if the baby started having distress or intrapartum hypoxia right at the time of birth, or maybe 1 hour before the time of birth, it might become quite difficult for us to manage this baby postnatally with therapeutic hypothermia. We will discuss this again when we discuss the HELIX trial. The other potential problems are coexisting infection and a large proportion of low birth weight and SGA infants who may be more vulnerable to the side effects of hypothermia and hypothermia related morbidities like, for example, pulmonary hemorrhage. Nevertheless, there has been lot of evidence literature coming from Indian studies. The medical institutes in South India, particularly JIPMER as well as CMC Vellore, have been fundamental in kind of steering a lot of research in therapeutic hypothermia from our country. And then, of course, we had a multi-country trial of which India was one of the components, HELIX trial. So these are all some of the early trials which were performed mostly in JIPMER Pondicherry as well as in Christian Medical College, Vellore. Most of the studies used low technology devices like frozen gel packs because that was the only available device at that point of time, and they performed whole body cooling. So you can see that the sample sizes were 58 to 62 newborns in these studies. Therapeutic hypothermia had been shown to reduce the combined rate of death or developmental delay up to 6 months of age in these studies, and some of them looked at markers of oxidative stress as a corollary for therapeutic hypothermia associated brain injury. So most of the studies did show encouraging results, even though they use low technology devices. Similar outcomes were also seen from the studies from CMC Vellore by Dr. Niranjan Thomas and group, where whole body cooling with frozen gel packs was found to be feasible as well as safe, and they pioneered the initial kind of development of the phase changing mattress or Mira cradle, which was quite rampantly used at that point of time. In some of these trials, because core body temperature could not be done, skin temperature probes were used for monitoring the temperature. Although this came with its own practical challenges, these were some of the early trials that were performed on therapeutic hypothermia. This was later kind of questioned, or it became more and more suspicious when some groups, particularly Dr. Sudhin Tail's group, kind of showed that in small studies, therapeutic hypothermia may not really reduce brain injury, which was apparent on MRI. And then eventually they came up with this multi-country trial, which was hypothermia for encephalopathy in low-income countries, or HELIX trial. So this was one of the largest trials published from the low and middle income countries, with the objective of examining the feasibility of whole body cooling using an inexpensive servo control cooling device, a variant of the Ticotherm device which was used in this particular study, which used manual rewarming and servo controlled cooling phase. So a total of 428 newborns were enrolled in the HELIX trial, and they were randomly assigned to receive either hypothermia or the control intervention. And what the HELIX trial found was that the primary outcome of death or disability was not so significantly different between the two groups. But when they only looked at death as an outcome, it did come out from the HELIX trial that the incidence of mortality seemed to be significantly higher in the group of newborns who had received therapeutic hypothermia when compared to those infants who had received the control arm intervention, that is standard care. So why did therapeutic hypothermia not work in the HELIX trial? This was something which was discussed extensively. Some of the reasons that were quoted were these. Possibly, a lot of newborns enrolled in the HELIX trial had more partial and prolonged hypoxia. This was because the authors did not necessitate the presence of severe metabolic acidosis in the cord gas in order to make the inclusion criteria more practical or more pragmatic. They did away with cord blood gas as one of the inclusion criteria. So if we had seen severe metabolic acidosis in the cord gas, that would have been more indicative of acute hypoxia. So it was suspected that most of the newborns who had been enrolled in Helix trial possibly had partial prolonged hypoxia, not really acute hypoxia, and hence therapeutic hypothermia may have ended up being ineffective. So this was also rendered possible because of the higher inclusion of outborn infants in the centers included in the Helix trial. These infants could have presented late with varying degrees of subacute or partial prolonged hypoxia due to deficient prenatal and perinatal care. This was also supported by the fact that MRA finding of majority of the term infants included in Helix trial was suggestive of periventricular white matter injury, more like periventricular leukomalacia seen in preterm low birth weight infants, which is also a finding that we see in subacute or partial prolonged hypoxia compared to more hypothalamic injury or basal ganglia injury in acute intrapartum hypoxia that is seen with the TOBI trial or NACHT trials. Additionally, more than 70% of the infants included in the Helix trial were born outside of the design centers. So all these, as well as the hypothermia-mediated liver decompensation, could have potentially led to a lack of effect and potentially also an increased risk of mortality in the cooled group. Now, the fact that even in high-income countries, only around 24% reduction in death as well as neurodisability has been achieved with therapeutic hypothermia has resulted in an ongoing search for other ongoing neuroprotective measures. And one of the most encouraging measures has been erythropoietin, which has been found to, as an immediate response to hypoxia, may potentially improve oxygen consumption as well as storage in the hypoxic brain by, as normally is produced by astrocytes and oligodendrocytes in the brain. It may decrease hypoxia-induced nitric oxide reactive nitrogen species search as well as may increase antioxidant levels. It also inhibits glutamate-mediated excitotoxicity and inhibits apoptosis of the brain cells. So these are all potential mechanisms of erythropoietin in hypoxic ischemic encephalopathy, and the effects are usually dose and timing dependent. These are all some studies that have used erythropoietin, and these are the doses that have been used in these trials have also been listed in the intervention as well as the timings of administration. Most of the studies showed encouraging results wherein improved long-term outcomes as well as improved neurological outcomes were witnessed in those babies who received erythropoietin versus the control groups. Erythropoietin has also been added along with hypothermia as an add-on intervention and also has been found to be encouraging in asphyxia. So to conclude, the following messages are clear. Effective therapeutic hypothermia can be used if one has significant access to other routine standard care as well as robust protocols and training of the healthcare providers for providing right kind of therapeutic hypothermia. The systematic review of randomized controlled trials from low and middle income countries used these trials which were included in the systematic review. We can look at the inclusion as well as the exclusion criteria. So in effect, there has been no significant effect on neonatal mortality with therapeutic hypothermia therapy in low and middle income countries. So it neither decreases nor increases mortality as was shown in the Helix trial. But there are some problems of using therapeutic hypothermia which one needs to remember because of the higher incidence of maternal malnutrition, IUGR, and the high incidence of obstructed labor as well as suboptimal obstetric or neonatal care. One has to remember that therapeutic hypothermia may not be uniformly efficacious in low and middle income countries. More than 2/3 of deliveries may happen outside the hospital. Hence, we do not know whether we are aware of the exact timing of hypoxic insult in outborn babies. The usefulness of cooling may also be reduced if there is high incidence of pre-existing brain damage, as can be seen in SGA babies. There can be coexisting neonatal sepsis with neutropenia and leukopenia, which can also become difficult to tackle in low middle income countries. So the exclusion of infected infants is unlikely to be realistic because and core temperature reduction may result in neutrophil compromise. So this, when combined with ongoing sepsis, can further kind of worsen the outcomes of the babies. All these factors, as well as accidental hypothermia, may contribute to the high rate of morbidity that can be seen in low and middle income countries with therapeutic hypothermia. Coming to the last part on cost, the cost of therapeutic hypothermia devices ranges based on the type of device that is being used. It can range anywhere between around 2 to 3 lakhs for the low tech devices. The phase changing mattress is usually available for around 3 to 3.5 lakhs price, whereas most of the servo control devices are generally available for prices that range from 8 lakhs for some Indian devices to as much as 15 or 16 lakhs. Some would also offer the addition of amplitude integrated EEG, which can be added to the armamentarium of therapeutic hypothermia. So the 4 Ps for optimal implementation of therapeutic hypothermia include place, personnel, paraphernalia, and protocols. So in terms of place, well-established level 2 or level 3 NICU, we may need for adequate monitoring. And in terms of personnel, we need trained pediatricians and nursing staff, especially with the low technology devices for round-the-clock monitoring of core temperature. In terms of paraphernalia, we need a radiant warmer, cooling device, rectal temperature probe, multi-para monitors for diligent monitoring, as well as blood gas machine, mechanical ventilator backup for ventilating the baby, glucometers. And desirable would be to add amplitude integrated EEG as well as MR facility, which is available in-house. And finally, protocols, which is in the form of timely identification of HIE, identifying newborns with the appropriate inclusion clinical criteria for HIE, and ensuring therapeutic hypothermia for eligible infants within 6 hours, and using evidence-based standard protocol for managing the comorbidities. So while all the concerns about therapeutic hypothermia in low middle income countries still do exist, one has to remember that there have been a lot of encouraging data that is available from most Indian units. And provided one is able to balance optimization of healthcare personnel, protocols, and provision of adequate infrastructure, it is possible to provide therapeutic hypothermia optimally, even in countries such as ours. Very, very important to remember that the window period for therapeutic hypothermia is short, and hence the appropriate identification of newborns who might benefit from therapeutic hypothermia is very, very important for achieving optimal efficacy. Safety in India remains a challenge because of the high number of unbooked pregnancies, obstructed labor, high proportion of missed intrauterine hypoxia because of challenges in intrapartum monitoring. Intrauterine growth restriction rate may be higher, and a large proportion of SGA babies. Natural selection, wherein HIE may not make it to the NICU, which is a large proportion of babies who may die while being transferred to the NICU, and a large proportion of accidental hypothermia, and the fact that hypothermia is more efficacious and moderate than severe HIE. So to conclude, to make therapeutic hypothermia maximally effective, there must be improvements in all aspects of antenatal and intrapartum care, and just providing therapeutic hypothermia alone may not be sufficient. So initially, it is better to restrict hypothermia to those centers which are able to provide very good intrapartum monitoring, as well as centers with good postnatal NICU holistic care, as well as nursing support. The burden of death and disability in developing countries demands that as evidence-based intervention strategies are implemented, more and more low-cost and effective therapy should be assessed urgently through well-powered studies. Cooling is very much possible in all resources, in all types of settings, and it can be made more inexpensive by innovative measures. Hence, every effort must be taken to identify those babies who will benefit from the intervention and optimize the implementation of therapeutic hypothermia in these setups. So with this, we will just take 2 minutes and we will kind of set up therapeutic hypothermia and we will demonstrate the practical working of therapeutic hypothermia to you.